I would like to introduce him. His name is Dr. Ross Renew, currently an associate professor of anesthesiology at Mayo Clinic College of Medicine and Sciences in Jacksonville, Florida. He also serves as the vice chair for research and associate residency program director for the Department of Anesthesiology and Perioperative Medicine at Mayo Clinic in Jacksonville. A proud graduate of Clemson University and South Carolina University School of Medicine. Dr. Renew has published countless articles and reviews on the topic of neuromuscular blockade monitoring and is revered as one of the world's foremost experts on the topic. Please join me in welcoming Dr. Renew and thanking him for presenting on this important topic this evening. Dr. Renew, the floor is yours.
Excellent. Thank you, GW. Click over and share my screen and get rolling. Look okay?
Looks great.
Great. Excellent. Well, I think I want to start off by thanking Senzime for sponsoring this this webinar and giving me the opportunity to talk to you guys about a topic that I'm truly passionate about, and there's a number of new technologies coming to market, and I think quantitative neuromuscular monitoring is an example of the industry answering the call from clinicians that, hey, we need new monitors, we need new technologies to combat postoperative residual weakness. And so there's a lot of neat things that I'm looking forward to sharing with you guys this day. This presentation takes about 45 minutes. I'm going to allot 15 minutes at the end of the time for questions, should any arise. And also, I don't have the chat function pulled up in front of me, and so I won't be able to look at the chat until at the conclusion of when I'm done talking. So thank you all for joining. I do have a couple of disclosures to share with you real quick. I've authored a couple of chapters and up to date on this topic and receive an honorarium for my efforts there. I've also completed Merck-funded research with funds to my employer. If I use anything off-label, if we get into that realm, I'll be sure to identify any off-label uses of medications or devices as well. Tonight, this evening, I have a couple things that I'd like to make sure we address. We need to start with nomenclature first and making sure that we are using consistent, accurate terminology and definitions when having a conversation about objective monitoring or quantitative monitoring. Also, we'll review briefly some patterns of neurostimulation, a couple of which are more important, particularly when we're monitoring at the hand. I'll talk to you about muscle sensitivities and different muscle groups of interest as they relate to both onset of neuromuscular blockade and recovery of neuromuscular blockade and the impact that that can have on objective monitoring. And then we'll talk about specific monitors, but we're going to do it based on modality. And modality means that the method with which these objective monitors obtain their objective measurements. We'll go over that in great detail. And finally, the thing that I'm most excited to address with you guys, and what I'm kind of saving the best for last, is I want to give you some practical pearls tips on how to introduce and implement objective monitoring into your practice. I do come with a couple assumptions, though. There's a couple things that this presentation essentially was not going to dive into. 45 minutes, I could talk for hours on this topic, but I want to make sure that we really focus and narrow the scope to objective monitoring. So I take a couple assumptions with the fact that this audience has signed up voluntarily, presumably, to watch an hour-long presentation on quantitative monitoring. And so I don't want to belabor the point and try to convince you that postoperative residual weakness is a chronic patient safety threat. I think that everybody in this audience already recognizes that. Okay, it's alarming looking through the literature to see the incidence of postoperative residual weakness being largely unchanged for decades, despite advances in other fields, other areas of anesthesia. We have just done a lousy job at really addressing this to this point. I also assume that everybody in the audience knows that neuromuscular blockade antagonism, meaning neostigmine and Sugammadex, are an evidence-based technique to restore neuromuscular function. And so I'm not going to go into a whole lot of detail about reversal strategies, okay? And I also assume that because you signed up for again, a webinar that addresses quantitative monitoring, that you recognize that this is an evidence-based approach to reduce the complication that is postoperative residual weakness. So I don't want to go into a whole lot of detail on why objective monitoring reduces postoperative residual weakness. There's an abundance amount of evidence, and please feel free to reach out to me offline. I'd be happy to provide any of that literature if you wanted to go down that road as well. But finally, one of my biggest assumptions is that, and maybe this isn't so much as an assumption as you need both reversal and monitoring to really attack this problem that is patient safety, that is postoperative residual weakness. Okay, you can't have one without the other. You can't just blindly give a boatload of Sugammadex and assume that your patients won't have postoperative residual weakness. Okay, really, the issue that is postoperative residual weakness, in my opinion, requires a multifaceted approach in which we use our technologies, our monitors, in conjunction with our neuromuscular blockade antagonism, neostigmine, Sugammadex, so that we can reduce this patient safety threat and ultimately enhance the safety profile of our patients in the perioperative period. And I'll share with you briefly a quick article that kind of looked at this. This is from Japan. Japan was lucky because they got Sugammadex earlier than anyone else. They were one of the first markets to get Sugammadex available. And I get this question very, very often, and so I'm trying to be proactive in addressing it. If I have unrestricted Sugammadex use, do I still need quantitative monitoring? So this study looked at Sugammadex use without quantitative monitoring. It was a single center. This is about 8 years ago, and wouldn't you know it, almost half their patients still had some residual weakness with blindly given Sugammadex. Which ultimately led the authors to state, we found that reversal with Sugammadex failed to eliminate the occurrence of postoperative residual weakness. And I think that this results from the fact that you need to know what depth of blockade your patients are at to pick the appropriate Sugammadex dose. And then finally, with any medications we give in anesthesia, we wouldn't give a medication for hypotension and not recheck the blood pressure. We wouldn't just assume that the phenylephrine or ephedrine that we gave in that instance would improve the blood pressure without confirming via our monitors. And so that's how I think of using reversal agents with monitoring. We give the reversal agent knowing that it is going to restore neuromuscular function, but that does not mean we should not confirm with our monitors. Okay. A little bit more on nomenclature. I'm not going to talk too much about clinical assessment this evening with you. Clinical assessment is a historic practice that really must be abandoned. It refers to when someone comes to me after a talk and says, "Hey, I don't need to use quantitative monitors. My patients are never weak." And I say, "Well, how do you confirm adequate recovery in them?" "Well, they squeeze my hand, or I look at big tidal volumes on the ventilator, and then I know that they're going to be nice and strong." Well, there's robust literature that says that using clinical assessment, these tools to try to declare your patient recovered and that their neuromuscular function is restored, it's neither sensitive nor specific. You need oftentimes a cooperative patient in this instance, which can be really tough as patients emerge from anesthesia. And really, there's no role for this in modern anesthesia practice anymore. It needs to be abandoned, and that's all I'm going to say about clinical assessment. The next thing I want to talk about is peripheral nerve stimulators, and I would bet that there's people in this audience right now who utilize a peripheral nerve stimulator and they're thinking about switching to quantitative or objective monitoring. And I'm not going to go into the best ways to utilize peripheral nerve stimulators. There are algorithms out there, evidence-based algorithms on to try to optimize the way you can use peripheral nerve stimulators, but still, even the best algorithms, even best practice with a peripheral nerve stimulator fails to reliably reduce this complication that is postoperative residual weakness. And I also want to take a moment to look at the nomenclature specifically for peripheral nerve stimulators, because a peripheral nerve stimulator does exactly what it says it does. It's a nerve stimulator. It's not a monitor. Okay. The monitor, when you're utilizing a peripheral nerve stimulator, is the clinician in this instance. When the clinician is then tasked with either feeling the response to neurostimulation, a train of 4 count, or observing the train of 4 response, and then making an inference on what the if is there any fade or not, as far as when trying to determine recovery. And there's strong literature that suggests that we, as clinicians, even experienced people who've been doing it for a number of years, you just can't detect fade above a train of 4 ratio greater than 0.4. You can't detect adequate recovery reliably with a peripheral nerve stimulator in this setting. And the final phrase that I want to make sure I'm clear on, and I've already done it a couple of times with talking, is I will routinely use either objective monitoring or quantitative monitoring when referring to the devices that I'm going to be talking about. They're interchangeable. These devices stimulate a peripheral nerve, like a peripheral nerve stimulator, but what's different is they've got an extra layer of technology, an extra layer of complexity that allows for the quantification of the response to neurostimulation. And rather than the clinician having to infer or take best guess at whether there's fade or not, these devices provide an objective measurement of what the train of 4 count is, what the train of 4 ratio is. If you're using post-tetanic stimulation, it can tell you what the post-tetanic count is as well. And so there's no guessing when utilizing these. And so that'll be the bulk of the focus of this talk. These devices are named after the method with which they display these quantitative objective measurements. And we'll go into the monitoring modalities a little bit later. Patterns of neurostimulation. I know you guys will know some of these and are probably very familiar with some of these, but there may be some that you need to brush up on a little bit, particularly if you're going to be trying to monitor the hand utilizing an objective monitor. And I'll go into reasons why. The first pattern of neurostimulation, I'm not going to spend a lot of time on single twitch neurostimulation, but many of these devices, these objective monitors I'll be showing tonight, have single twitch capabilities. Single twitch refers to a single impulse every 10 seconds. Okay, this is useful at the start of a case to get a amplitude control in an unparalyzed, and then you refer to subsequent responses to single twitch as a ratio of that initial response. Really, single twitch has kind of fallen into more of just a research modality. Actually, it's used for dose response curves for new neuromuscular blocking agents. And so while some of these devices have that modality present in them, I don't routinely utilize this unless it's for research purposes. Train of 4, this is the workhorse pattern of neurostimulation, the most common. I'm sure everyone on this call is familiar with train of 4. This is 4 responses, half a second apart. If you have, it'll give you either a train of 4 count, if you have 0, 1, 2, or 3 responses to train of 4 stimulation. If you have 4 responses to train of 4 stimulation, now you can calculate that train of 4 ratio T4 to T1, and we'll talk about that in a little bit more. Double burst stimulation, I'm also going to gloss over. This is a pattern of neurostimulation that was utilized to try to get clinicians better at utilizing a peripheral nerve stimulator. This came around a couple decades ago. And instead of having all 4 twitches with the as present in train of 4 stimulation and trying to have the clinician make a judgment on just the last and the first twitch, it kind of cuts out the second and third twitch and compresses it so they can compare consecutive measurements. And we got a little bit better at detecting fade with double burst stimulation up to a train of 4 ratio of 0.6, but nonetheless, we can't reliably confirm adequate recovery, even with double burst stimulation when utilizing a peripheral nerve stimulator. Some of these quantitative monitors do offer double burst stimulation patterns as well, but I don't view that as very useful or necessary, and I don't routinely utilize this as well. One pattern of neurostimulation that you may not be as familiar with, that you may not have used a whole bunch, is post-tetanic count. We'll talk about that a little bit more in a second, okay? And so we do need to spend some time, make sure you guys are comfortable with post-tetanic count as a pattern of neurostimulation. Quickly coming back to train of 4 patterns of neurostimulation, it can also be diagnostic for either telling you depolarizing versus non-depolarizing pattern induced neuromuscular blockade based on whether there is any degree of fade, meaning that T4 response to neurostimulation is less, has a lower amplitude than that of the first initial twitch. Okay, so train of 4 count lets us describe moderate levels of blockade. And that would be a train of 4 count of 1, 2, or 3. Train of 4 ratio. Now I have 4 twitches. I have 4 responses to a train of 4 stimulation, and using an objective monitor, it will take that fourth twitch, put it over the first twitch, and present that as a percentage. And once we reach 90% in there of the T4 to T1 ratio, as measured at the hand, then that is our current working definition for adequate recovery. I'll tell you that that definition has changed over the past years. A couple decades ago, it was we were utilizing 0.7, but we found some work that even at low levels of residual weakness, low levels meaning a train of 4 ratio of 0.8, just below 0.9, there were still post-operative complications related to post-operative residual weakness. So we've raised that threshold to try to ensure we're not leaving patients with residual weakness. Post-tetanic count. So this is a 5-second tetanic stimulation, usually 50 hertz, and then a series of single twitch stimulations, 1 second apart, up to a count of 20. The part where post-tetanic count is especially useful is when you have a deep level of blockade. When I start talking about different muscle sensitivities, remember post-tetanic count, we're going to touch on this. It's an important technique to consider when you're monitoring the hand and trying to make judgments based on how paralyzed the diaphragm is. Okay. The one caveat to post-tetanic count, you can't do it very, very often. That tetanic stimulation mobilizes a lot of acetylcholine, increases the concentration at the synaptic cleft, and so it takes a couple minutes to wash out. So this is not a pattern of neurostimulation that you can do frequently. You need to allow a couple minutes washout. Most of the devices themselves prevent you from performing a post-tetanic count in rapid succession to try to prevent that. It's amazing looking at the literature how even researchers in neuromuscular blockade cannot agree on what level of blockade our patients have, or what level they're even targeting in their research efforts. I'll read a method section and they'll describe how they assessed level of blockade, and they'll describe to me what I would call a minimal level of blockade, but they would call it a moderate or a deep level of blockade. And so it has been all over the place, and that's why the devil is in the details when looking through the literature. But I use the definitions that were presented in the consensus statement that came out 3 years ago in Anesthesia and Analgesia. This was published by an international panel of experts, and they sat down and agreed upon level of blockade. How are we going to describe it? What constitutes what level of blockade? Okay, I kind of think this analogous to like the ASA classifications or like Malampati. You know, we're used to making some kind of small numeric scale so that we can standardize how we're referring to whether it's how sick our patient is or how difficult we think the airway is going to be, but also what level of blockade our patient has. Okay, and so we've got level 5 being a complete level of blockade. This is like right after a big slug of rocuronium, and the patient has no responses to neurostimulation, not even post-tetanic count. A deep level of blockade would be now we have some post-tetanic responses, getting even lighter. A moderate level of blockade, I will be referring to this as a train of 4 count, 1, 2, or 3. And then once we have 4 responses to train of 4 stimulation, that's either going to be a shallow or minimal level of blockade, depending on what that train of 4 ratio is. And then I alluded to this earlier, the definition for adequate recovery can only be determined by using a quantitative monitor, and that's a train of 4 ratio greater than 0.9 as measured at the adductor pollicis muscle. Okay, I think it's really important that we're consistent when describing this, not just for research purposes, but it's also important for handoff. If you're handing a case off to a colleague, or if you're transitioning care to the recovery room, we need to be utilizing standard descriptors for this because it's important and it has big impacts on our patient management, knowing and having a good grasp on what level of blockade our patients have at the time. Monitoring sites is very important. We need to cover that as well. The sites that we're going to talk about specifically are the hand. We're going to briefly talk about the face, talk about the diaphragm, which is really an elusive site. We cannot currently directly measure the diaphragm, but we all very much care about how paralyzed the diaphragm is. And then finally, I'll briefly touch on the foot as a monitoring option. So there's a number of devices, really all the objective devices I'm going to show you tonight have a work on the hand, are designed for the hand even. If you're going to monitor at any other site besides the hand, some of these devices, they sell accessories and different things that you can utilize to work on different sites. But most of them are designed to work at the hand. There are 3 muscle groups that you can measure the response to neurostimulation after stimulating the ulnar nerve. Okay, the first one is the adductor pollicis. It's the most common. This is the thumb contracting. This is what most devices measure. However, you can also measure the 5th digit, the pinky, the adductor digiti minimi, and reliably get objective monitoring, objective measurements with some of these newer devices, as outlined in this middle picture on the bottom of this middle picture. And then there's one other muscle group that's a little bit more obscure that you may not have heard of as far as a monitoring site, and that's the first dorsal interossei muscle. This is the muscle that is it's the web space between the thumb and the index finger. And this is the picture on the far right with the blue background. This can also be monitored and measured with electromyography, and some of these devices are designed to measure that response. We like this site because look where the electrodes are, the stimulating electrodes are over the ulnar nerve. There is significant real estate between the site that we're measuring, whether it's the thumb, the pinky, or the first dorsal interossei, and where we're stimulating the nerve. So the hand really minimizes the chance of you getting direct muscle stimulation, which would overestimate the degree of recovery in your patient. And that's really why the hand has become an ideal monitoring site for most of these technologies. There are some caveats to use in the hand, and we'll talk about that in a little bit as well. The face is another site that you're familiar with monitoring or using probably with your peripheral nerve stimulator. It's very convenient because it's right there at the head, close to our anesthesia station many times. Tons of literature out there, though, that we overestimate the degree of recovery when we use a peripheral nerve stimulator on the face. You can use objective monitoring on the face. This is me using an Acceleromyography device on the face. I'm trying to fix the transducer to the eyebrow of this patient. It can work. I'll tell you from personal experience, it's a little challenging because the innervation of the facial nerve, when it's innervating, whether it's orbicularis oculi or corrugator supercilii, these muscle groups are very, very small. They're interwoven, they overlap, they're closer to where we're stimulating, where the stimulating electrodes are. So now we're at an increased risk of having that direct stimulation. And so while it can be done, it's a little messy and it's tough. It's been tough for me to consistently do that. There are better options for monitoring our patients than trying to use acceleromyography on the face, in my opinion. The next site to talk about is the diaphragm. This is what we're interested in. We want to make sure the diaphragm is paralyzed when we go to intubate our patients. So, because if the diaphragm is paralyzed, then the pharyngeal adductor is paralyzed, and we're going to have better intubating conditions. We also want the diaphragm restored so that we have excellent ventilation capabilities to ventilate and breathe following reversal and at the conclusion prior to extubation. I got to remind you guys that the hand is one of the last muscles to get paralyzed. This is at the onset of a case. The diaphragm is one of the first muscles that gets paralyzed because a higher proportion of blood flow. So when I objectively monitor the hand to help at the start of a case to let me know when my patient's ready to intubate, I can be assured that if my hand, the train of 4 count is 0 at the hand, the diaphragm is almost undoubtedly always paralyzed because it gets paralyzed before the hand gets paralyzed. On the converse side of that, as muscles start to recover, the diaphragm recovers first. It is a hard muscle to keep paralyzed. It has a ton of receptors, very densely present on the diaphragm. And so as drug neuromuscular blocking agent starts to become metabolized and cleared, the muscle function will recover much faster at the diaphragm than at the hand. And so when you are monitoring at the hand, if you have a train of 4 count of 0, you can have spontaneous diaphragm movement because the diaphragm may already starting to be recovered. And so this does not mean that the monitor is not working. I certainly have been called into rooms before this, Dr. Renew, your device, it's not doing its thing. And I said, tell me about it. Well, I got 0 twitches on the hand. It says it right here, but I can see my patient making spontaneous ventilatory efforts on when I look at my capnograph on my ventilator. And that just, for me, hammers home the point that the diaphragm is hard to paralyze. And if you want to be assured that your diaphragm is paralyzed over the course of the operation, maybe it's like a hiatal hernia operation, or it's a laparoscopic surgery where you're really, really trying to keep that diaphragm paralyzed. If you want to keep it paralyzed, now the pattern of neurostimulation that you should be using to monitor your patient is that post-tetanic count that I talked about earlier. Okay, and so you give more drug now that the train of 4 count was already 0, but nonetheless you saw the patient moving on the moving their diaphragm on the ventilator, so you still give more drug. Well, how do you know where you're at this point? And that's where post-tetanic count comes in. Okay, if you can keep your patient at a post-tetanic count around 1, 2, 3, that diaphragm is much, much more likely to be paralyzed. When your post-tetanic count recovers to 8, 10, 12, and again, this is over 20 responses. So the denominator in this instance, rather than 4, is usually 20. If you have an 8, 9, 10 response to post-tetanic count, now you can know that in maybe 10, 15 minutes, you're close to getting the reappearance of your first twitch, that first T1 to train a 4 stimulation, which kind of helps you not feel like you're flying so blind by just empirically giving drug to keep your diaphragm completely paralyzed, if that's where you want to be. Okay. The foot, I've done it. Some of these devices, you're able to put the electrodes on it. Some of them require special accessories to let you monitor at the foot. Really, with a good monitor, though, you should be able to monitor at the hand almost any time. The only time you can't monitor at the hand is, if the patient doesn't have hands for anatomic reasons, or if they're like a burn patient, that can also be a problem. And then the other one that has popped up before is both hands are in the surgical field. Obviously, you're not going to be able to put your device on there. And these devices can be utilized. Many of them can be utilized at the feet. Monitoring at the feet has its own caveats. There's a lot more patients with peripheral neuropathy that can make this a little bit more challenging. I also find that the innervation of the foot, the flexor hallucis brevis, is a little bit more variable, and there's a little bit more anatomic variation than I was expecting in looking at it. And so a little bit more challenging, but can be done. Ideally, though, we're using a good monitor at the hand, in my opinion. And we put it on at the start of the case, and we're able to use it for the duration of the case without having to transition to like a peripheral nerve stimulator on the face when the arms are tucked, for instance. Okay, I've alluded to this a little bit. Let's talk about the ideal monitor. If I could design one that I exactly met all of my needs, I like portability. And I say this because postoperative residual weakness and the complications that come with it, respiratory distress, hypoxia, hypercapnia, aspiration pneumonia. These aren't complications of the operating room. These are complications in the recovery room. These are complications in the intensive care unit. And so being able to monitor your patients and diagnose postoperative residual weakness, both inside the operating room prior to extubation, as well as in these other remote sites, is very, very useful. So much of anesthesia too is transitioning to non-operating room anesthesia. We're really becoming Swiss Army knives of the hospital and going everywhere. And so I'd like to be able to take the device with me. Automated, most of our really all the objective monitors that I have used are automated. This makes it really nice because if I'm gonna have to learn how to use objective monitoring and the caveats to it, there needs to be some benefit on the back end of it after I've invested my time and the effort that goes into understanding it. And automation is certainly something that's useful. It's very, very helpful, and in my opinion, mandatory that it feeds into the electronic medical record, because it needs to make my life easier. It needs to make caring for my patients easier, so I can focus on them rather than having to document the whatever the response to the peripheral nerve stimulator was every 15 minutes or whatever, how frequently you want to do it. So integrating seamlessly into the EMR is certainly a characteristic. It needs to be easy to set up, pretty intuitive, easy to clean, and finally, it needs to also be cost effective. And there's going to be some investment on the front end of any of these new technologies. But by saying cost effective rather than saying I want a cheap monitor, cost effectiveness is appreciating and really convincing the decision makers at your institution that that these devices can be cost effective, because if you have to reintubate a patient in the PACU, that is a tremendously expensive endeavor. And while I can't give you the exact number needed to treat how many people you need to monitor to prevent just one patient from getting reintubated, it certainly has cost savings in that regard. The cost of a postoperative aspiration pneumonia is also very, very costly, prolongs hospital stay. In an era where we're trying to get people out of the recovery room faster, enhance their recovery, get them out of the hospital faster, it is but a small leap, in my opinion, to suggest that quantitative monitors that reduce postoperative residual weakness can indeed be cost effective, obviously with some front end costs. And then the final thing I'll say is, and I alluded to this a little bit, I want to be able to put the monitor on. I want to be able to allow the surgical team to tuck the arms if they deem that the best position for that patient. And I want to be able to continue to use the device throughout the perioperative period, independent of what the arms are being done, whether they're tucked or untucked. Okay. These are some fun pictures that I have from a colleague of mine who shared them with me. These are old quantitative monitors, and you look at these things, and they were actually getting ready to throw these out, and I've got them stashed in my garage now. I couldn't part with them, but I mean they're analog. They take up a ton of room in the operating room. They just look pretty neat. They look like something out of Back to the Future to me, and this is to show you where we were, what monitoring looked like 30, 40 years ago and where we're at now, because it is exciting now, some of the devices that are out there currently. So let's transition and start talking about quantitative monitoring modalities, the actual modalities that are out there. I have to give justice to the historic gold standards, that is mechanomyography. I'll lead with the fact that there are no commercially available mechanomyography-based devices. Mechanomyography directly measures isometric force contraction. These devices, there are a couple of them out there in the world that they are used predominantly for research purposes. The setup is cumbersome. There's a significant effort that goes into calibrating them and getting them set up. And so really not ideal for clinical care. Certainly useful for research purposes, but not ideal for clinical care. The next form that I'm going to talk about at length is Acceleromyography. And we need to talk about this one particularly because it's one of the most frequently studied modalities. And there's a number of devices currently on market that are available, that are FDA approved, that are based on Acceleromyography. So AMG measures acceleration. It's based on Newton's second law, force equals mass times acceleration. Excuse me, with the idea that the mass of the thumb doesn't change. And so now I can start saying that force, like in mechanomyography, is directly proportional to the acceleration. As we're measuring acceleration via these transducers that get fixed onto the muscle of interest, usually the adductor pollicis, we need it to be able to freely move. Okay, and if we tuck the arms in a certain manner, oftentimes this fails. AMG devices often use the EKG leads that you already have sitting around in your department, which makes them a little bit more convenient. There's two kind of vocabulary words that we briefly have to touch on that are specific to AMG. The first one is this idea of reverse fade. And this does not inspire confidence in people getting used to quantitative monitoring for the first time. Reverse fade refers to when I take a baseline train of 4 ratio. Patient is not paralyzed, okay? And we haven't given any of the drug yet, but the response comes back greater than 100, meaning T4 is greater than T1. Why is that? We've never really quite teased out the exact modality or the exact mechanism with which reverse fade happens, but nonetheless, it's well described. It is consistent across many different AMG platforms. Reverse fade, it's something that has important clinical implications that I'll get to in a minute. And the other vocabulary term is the staircase phenomenon. Remember back to that single twitch pattern of neurostimulation that I talked about? For whatever reason, in an unparalyzed patient, again, the amplitude, the response to neurostimulation can actually increase in an unparalyzed patient, which is a little confusing, probably related to a similar mechanism as that of the reverse fade. So staircase phenomenon and reverse fade specific to AMG monitoring. Newer technologies that have come out, rather than using a single dimension transducer, there are 3D transducers that are out there, because the movement of the thumb in response to neurostimulation is complex and happens in more than one vector planes. And so some of the newer devices utilize three-dimensional transducers that better capture this. And Glenn Murphy and his group have investigated this. And, if you use a preload device refers to a resistance device that kind of opposes neurostimulation, the thumb moving. If you use these 3D transducers, these newer ones, and you use a preload device, you can get a pretty good level of precision and agreement, assuming that you have good positioning as well. There's a couple other terms that we need to talk about as well: calibration, normalization, and I'll touch on those in a second. Can I still tuck the arms with AMG? I've told you that it fails with acceleration. That it fails when the thumb can't accelerate, can't freely move. We have previously used AMG at my institution. I have experience with it, and so it's actually interesting. We were able to teach our nurses, who are the ones that are frankly tasked with tucking the arms, if they see one of our AMG devices on, they know to try to tuck the arms up proximal to where the thumb is moving, to try to give it its best chance of moving freely without being obstructed. Now, that works in this instant for the initial start of the case, but when you put a surgical drape on it, when the surgeon leans over it, then the thumb becomes restricted again, and it's really tough to reliably keep the thumb free when the arms are tucked when using AMG. Do I have to calibrate? I'm going to give you guys a pass on calibration. I am of the opinion that calibration is really a technique, a feature that is probably best suited just for research purposes. What calibration refers to, and in this video, I'm kind of going through the steps of calibration while I apply one of our older AMG devices. Calibration refers to finding the best current to stimulate the patient to obtain your objective measurements. It starts at a low current, 10, 20, 30, 40, 50 milliamps, and increases until it finds the optimal current. When it finds that optimal current, it actually all these devices adds 10 milliamps to get super maximal stimulation, okay? A lot of the newer AMG devices default at 50, 60 milliamps current. So, and say, hey, you don't need to calibrate, which is probably true. If you're going to do that on a paralyzed patient, 60 milliamps is very acceptable, and it gives a good, reliable measurement. The reason why you wouldn't just always crank it up to 60 is calibration helps us find that level of noise that is present in the background versus what the optimal pattern of neurostimulation is. But really, I'll give you a pass on this. I don't think you need to routinely be doing this for clinical purposes. I think this is really important for research purposes, though. What about normalization? How do you normalizing AMG? Let me describe that first, because in the previous slide, let me go back to that and play that one more time. In the previous slide, I wanted to make this point. The response, this is an unparalyzed patient, and this is going to be on the right. We're about to see the train of 4 ratio here. This patient is not paralyzed. They're frankly not even anesthetized because this is a video shoot. Look at the train of 4 ratio, and remember that I told you that the response is higher. It's 119. Okay, so the train of 4 ratio in that unparalyzed patient was 119. Let's refer back to that example when we talk about normalization. If I extubate this patient and the AMG device shows me that the train of 4 ratio is 90%, when I normalize that and consider that the baseline was 119%, now their normalized train of 4 ratio is really only 74%, which is not adequate recovery. This patient could actually have postoperative residual weakness and complications from it. So to normalize it, taking 90% of that 119 baseline, now we get into, we should be targeting 108 prior to extubating this patient. When you're using AMG, you need to normalize the values because the baseline values are often higher than 100%. Kinemyography, I'm briefly going to touch on. Kinemyography is it's really a sister of AMG. It is basically AMG, but instead of measuring acceleration, we're measuring the degree of bend of the preload device, the piezoelectric sensor that is wedged between the thumb and the index finger. Okay. this is less precise of a modality, and that's because it's very dependent on where you put this piezoelectric sensor between the fingers. It can wedge into different places and it can move, and so it's not as precise, not as good for research purposes, but just really not as consistent overall. And the literature has bared that out. But because it does have that kind of built-in preload device, it's not associated with that reverse fade, the phenomenon that I talked about. There's one KMG device that's currently available, that's FDA approved, that's out there. I know of one institution that uses KMG. Otherwise, I'm not familiar with a lot of people currently using KMG. EMG is the electromyography is, if you talk to the experts, the people who really, the nerds who really get into this kind of literature, this is where people are really excited about, and I'll tell you why. So EMG measures action potential following neurostimulation. It does not measure acceleration. It doesn't measure how much that little sensor bends. It's measuring electricity, action potentials. So one of my favorite things to do is to put it on an EMG device on myself, hold my thumb down, restrict my hand, and hit the button, and I can get a consistent train to 4 ratio of 100% while my thumb is unable to move. It's pretty neat to see and show people. Does not require freely moving thumbs. You put it on at the start of the case. You use it to guide when it's time to intubate the patient. You use it to redose. You use it to determine when you need to give when and how much reversal agent, neuromuscular blockade antagonism, and you use it to confirm adequate recovery prior to extubation. And it's been validated as a modality with mechanomyography. It does have a couple caveats that we need to discuss. Because we're measuring electricity, the portion of, you can get some interference with that, and most of these devices kind of flag it if there's noise from electric cautery. If the patient gets cold, like really cold, below 34 degrees, it can overestimate the responses, and something to consider around that time. You can't use EKG leads at EKG electrodes that are sitting around your department. Most of these devices utilize proprietary electrode systems that are out there and available. And then there's a newer one that I don't want to spend a whole lot of time on. I've talked with these manufacturers a little bit, and this is the Vision Duo is the brand name. It used to be called the Tofcuff. It's kind of like modified compressomyography that I can tell. These guys are coming to market here shortly in the United States. They're trying to incorporate a blood pressure cuff and a neuromuscular monitor all in a single device. I have not played with this yet. It's been in Europe for a couple of years, and there's a couple smaller reports on this. Detect changes in the changes in pressure peaks with an inflated cuff following neurostimulation of some of the innervation of the upper arm. So probably more to come on that. We'll have to keep an eye on this monitoring modality going forward. So I gave you an overview on some of the modalities that are out there and present. So it's coming. The momentum is building. This is a hot topic, a very rapidly expanding area in anesthesia, and there are guidelines emerging. The Association of Anesthetists of Great Britain and Ireland recently released guidelines that specify strongly recommending quantitative monitoring whenever neuromuscular blocking agents are used, and they actually go on to specify EMG specifically for what it's worth. There's a number of other societies as well, the Czech Society, the Society of New Zealand and Australia, the Canadian Society as well, and as well as the French Society. All these societies have released guidelines, recommendations, practice protocols, either strongly urging or mandating the use of quantitative monitoring. And so you're seeing this momentum build in the literature. And I bring this up not to say that this is why you should be monitoring. I mean, we should be monitoring because it's the right thing to do for our patients. It enhances patient safety. But I think rather the fact that there are guidelines that are being presented is more of it's a thermometer that kind of tells you where things are moving, where other societies internationally are at as it comes to quantitative monitoring. In the last couple minutes or so, we're going to talk about how to get this into your practice, how to get comfortable being successful implementing this. Okay. If you want to do this, I say if you're only going to read one article, you have to read this article by Michael Todd. He was the chair of University of Iowa when they released this 7-8 years ago in anesthesia and analgesia. I mean, as far as I can tell, this is the only quality improvement project that was was robust enough to be published in such a robust journal. Basically, the background on this is he got tired of seeing his patients being re-intubated in his PACU, and he would do root cause analysis. And he went back to see, why is this happening? And ultimately felt that postoperative residual weakness was a huge contributor, the primary driver in a lot of these. And so he says, I've had enough of this. We're going to put quantitative monitoring, specifically, they put EMG in every anesthetizing location in his operating room. And it is fascinating to read this article because he talks about the change in culture that had to happen. You certainly, it's hard to get an anesthesia clinician who's been doing this for 30 years, and I've never had my patient have an issue with weakness. I've never monitored my patient. My patients are never weak. If you're not monitoring, then those patients, how do you really know if they're weak or not? But to try to get that individual who's set in their ways, this is how I want to do it because this is how I've always done it, to try to get that momentum, to try to get that change is really hard. It requires local champions, such as Dr. Todd and his colleagues, that are available to come in and help you troubleshoot, to help with the education, a tremendous educational effort as well. And he talked about some of the more interesting things that are, this is not in the article. He talks about incentivizing this, where he would do periodic audits of people's anesthesia records to see if they were using the device, if they were using it correctly. And he would offer, like, I think it was Starbucks gift cards to kind of incentivize this and make it a little bit more exciting, to try to urge people to get it. A year into his efforts, he was able to get universal monitoring in almost every case in his operating room, and they eliminated the instance of patients getting reintubated for postoperative residual weakness. They published a follow-up article a couple years later, and they found one patient that had to get reintubated, and when they did a root cause analysis, that patient got too many opioids. It was not because of quantitative monitoring. So really a neat thing. You need education, you need local champions, you need a strong effort if you're going to try to change the entire department all at once, such as the Dr. Todd did. I would also say, while I don't know the best strategy to introduce it, there is a less invasive approach where let's buy a couple monitors and see what we think. Let's check out a couple. Let's try quantitative monitoring to see what we think. Park it in the PACU. And this is something that I've advocated for in people that are interested in getting into it. Get a couple monitors, park them in the PACU, and just do spot checks on patients in the recovery as they arrive to the recovery room to really figure out how big of a problem postoperative residual weakness is in your practice. I think you'll be surprised at how many patients arrive with postoperative residual weakness. I share this article with you because one of the concerns that people say is, I don't want to zap people that are awake after anesthesia. I don't want to be doing that. We did this on volunteers. I've done a number of research papers where we zap people, obtain quantitative measurements in the recovery room, and it's very well tolerated. You can turn the current down without losing the ability to obtain a reliable signal. What we found is performing neuromuscular monitoring in awake, unmedicated patients. In this case, that we asked them to tell us how uncomfortable was that on a scale of 1 to 10, and it really was not all that uncomfortable. Everybody was able to complete the study for the most part, and it's not that bad. I've done it on myself a number of times. It's very tolerable. And remember, when patients are arriving in the PACU too, they're still pretty sleepy. They could be pretty sedated, and so doing a quick spot check to see if they have residual weakness with a quantitative monitor, turning the current down to 20, 30 milliamps is a very, very reasonable practice. The final pearl I want to give you in getting this into your practice is you're going to need to convince people that if you want to do this, that you're not going to slow workflow down. I mean, we practice in an era of heightened production pressures. I don't think any practice is devoid of production pressures and wanting to get patients in and out. The OR time is so expensive. Personnel time is so expensive that we need to be fast and efficient. And so there is this misconception that if I introduce quantitative monitoring into my practice, I'm going to be throwing a wrench into this entire well-oiled machine that is my current practice. In this effort, we took 20 experienced nurse anesthetists, and we timed them from the time it took them to put on a peripheral nerve stimulator and compared it to how long it took them to put on a quantitative monitor. And it only took about 19 seconds longer. And if you think that, I mean, if you think that 19 seconds is too long, we've had the idea of we could probably put the device on and have the PACU nurses put it on before we get there if they're appropriately trained, and cut that timing down even more. Nonetheless, 19 seconds, if we can't devote an extra 19 seconds for an endeavor that is evidence-based, that increases our patient safety, that enhances patient safety in the perioperative period, I'd completely reject that notion that that is too much time to devote to our patients, even in the highest production pressure environment. Okay. So I appreciate you guys hanging with me today, tonight, and sticking with me. I know that the nomenclature stuff can get a little dry, but I really hope that it all kind of builds to some of the ideas and the pearls that you can utilize to introduce with quantitative monitoring. To recap some of the things that I really want you to take home, post-tetanic count is something that I found that most people don't have as much familiarity with when we compare it to train to 4 ratio. This is a pattern of neurostimulation that's good for measuring deep levels of blockade. If you want the diaphragm paralyzed and you're monitoring at the hand, you're going to need to familiarize yourself with post-tetanic counts. Remember that once you get a post-tetanic count around 8, 9, 10, it's only going to be 10, 15, 20 minutes before we have the reappearance of the first twitch to a train of 4 stimulation. The diaphragm is really hard to paralyze. It recovers quickly. If you're used to monitoring at the face and then you start transitioning at the hand, just because the device says that the train of 4 count is 0 and you can see some spontaneous movement with the diaphragm, that does not mean the diaphragm that does not mean the monitor is not working. Rather, it means that you need to utilize a different pattern of neurostimulation, and that is post-tetanic count. KMG and AMG are one and the same, very, very similar monitoring modalities. They have concerns over positioning, though, as they measure motion. AMG, you don't necessarily have to calibrate it, but you absolutely need to normalize the value when using AMG because of that reverse fade phenomenon we talked about. EMG works when the limbs are restricted. Remember that it can pick up the interference from the cautery, but nonetheless, this is a modality that you can put on at the start of the case, use with the limbs restricted throughout the duration of the case. You can confirm adequate recovery prior to extubation with this device. Changing practice is hard. I get it. We're in a cost conscientious environment. It's much easier to keep doing what you've been doing. It is hard to change. But I want you to know that this effort, this change, this work is truly worth it. It's worth it for your patients. I'm going to stop sharing my screen now and open it up for questions.
Thanks so much, Dr. Renew. That was awesome. Awesome information. We do have a couple questions that came in. If you're okay to take them.
Absolutely.
In the last 5 minutes we got.
Yep,
okay,
sure.
Cool. First question that came across. Do you have any patient case examples that you could share to help understand where quantitative monitor may make a difference in actual patient outcome?
Patient examples. I think it impacts all patients, but if we want something that's very overt and obvious, the example comes to mind is we do a lot of robotic thymectomies. So patients that have myasthenia gravis and they are going to be under a robot, and the one school of thought is just don't give them any neuromuscular blocking agent. And you can use other things, propofol, remifentanil, to try to keep them still. And certainly my neuro colleagues do that pretty routinely. But I have been able to titrate smaller doses of rocuronium in this setting when I'm guided by a quantitative monitoring. And then utilizing in this setting, I routinely use Sugammadex because it doesn't have the same mechanism of action that neostigmine or their mestinon does, for instance. I think that has been tremendous. These patients are at extreme risk for having postoperative residual weakness, and so that's certainly an instance where it is enhanced. But really, I use that as an obvious example. But my opinion, the international panel of experts, the societal guidelines are anytime we're using neuromuscular blocking agents, we should be monitoring.
Excellent. Any watch outs? So you touched a lot on the implementation part, and even referenced the cost justification. But from a clinician standpoint, to make the argument to administration or materials management, are there any watch outs that you would, or arguments that you would use to justify a new expense for somebody who's implementing?
Yeah, I've been fortunate to always have pulse oximeters in my practice, but I know that, it's not been 20, 30 years that I've got colleagues who tell me, I remember when we didn't practice pulse oximeters and we had to convince administration to invest in pulse oximeters back then. And so comparable conversations have to be had with that. Looking at just the cost of the device, in my opinion, is short-sighted. And certainly, one instance of a patient having to go to the ICU and an unanticipated ICU admission is tens of thousands, approaching hundreds of thousands of dollars. And it's also you can argue the money too, but let's also remember that there's a patient in all of this, and certainly patient safety. I know it's not always the driver, but man, it should be. I advocate for that. But if you're going to get down to dollars and cents, there's some of the indirect costs. You can maybe even have some indirect cost savings with medications, maybe by knowing where your patient is, specifically the level of blockade. Maybe that helps you to be more precise with how you redose your neuromuscular blocking agent or how you target your reversal agent administration as well.
Awesome. You also touched on the guidelines, so I'll ask the question about the guidelines that came up. Globally, there seems to be a trend for mandating, or at least a strong recommendation for use of quantitative monitoring. Any explanation for the lack of consensus in the U.S.?
Yeah.
Why haven't there been guidelines in the U.S.? Are there barrier adoptions that cause that problem? So on and so forth.
I gotta like tiptoe a minefield in answering this question. Frankly, a lot of literature comes from outside of the United States. Quantitative monitoring is a much more part of the culture of the anesthesia community outside of the United States. We don't have guidelines for we have consensus statements, and we have expert recommendations. We have smaller societies recommending it, things like the Anesthesia Patient Safety Foundation. But our major societies have not tried to delve into this too much. And when I ask this question bluntly to people who are plugged in, maybe even sitting on these discussions, we still have a culture that is reluctant to add something that I think has a misconceived notion that will be burdensome and is not something that is realistic for all practices to actually implement, which I wholeheartedly disagree with. But I've heard conversations of this pop up from time to time recently as well, readdressing this, reinvestigating it. I haven't heard anything new if we're getting closer to guidelines. But again, like I said in the talk, guidelines are great, but we should do it because it's the right thing, not because of a guideline.
Yeah, absolutely. One more question. This one came in early on the chat line when you were talking about Sugammadex. I kind of figured whenever you talked about Sugammadex, there was going to be some questions that popped up. But with availability of Sugammadex in my facility, struggling with the argument to add monitoring and the associated cost with that. I think the general consensus is that Sugammadex basically eliminates the need for it. Yeah. But do we really believe that RNMB is a real patient safety issue when providers are using these newer reversal agents?
We have not eliminated it with just Sugammadex. It is better than certainly the older antagonist agents, neostigmine. There's less postoperative pulmonary complications. The MPOG group has shown that. But nonetheless, you need to know where level you're at when you're going to dose it. And there's so many instances of off-label dosing with Sugammadex. My patient's morbidly obese. Do I need to open a second vial? Do I need to open a third vial? Because now if they're 140 kilos and I follow their manufacturer recommendations of 2 milligrams per kilogram, I need to open up two vials to hit that 2 milligram per kilogram mark. But there may be cost-saving measurements because you can deviate from manufacturer recommendations if you are guided by a quantitative monitor. And so I think there could be cost savings. Sugammadex is still has its patent and is with the price of neostigmine decreasing a couple years ago, it is more expensive for sure. And so I believe that quantitative monitoring can potentially reduce not only Sugammadex, but maybe how much neuromuscular blocking agent you need as well. But nonetheless, I mean, what can you name another instance in anesthesia? I can't think of another instance in anesthesia where we just give a drug any drug and we just say, yeah, it works blindly, I'm not gonna check it. I mean, we are always, that's just not our culture. That's not our practice pattern. We give a drug, we check, we take a baseline, we see what the drug response is with our monitors. I think that it's certainly useful. The instance I gave in the using it as an example in the PACU, if you blindly give Sugammadex in the PACU and your patient gets in trouble in the PACU, do you just give more Sugammadex there, or can you exclude postoperative residual weakness without having to give more drug? You know, it's not a it's a drug. I mean, there's the hypersensitivity reactions are real. The bradycardia can be real. And so if we can avoid giving it, maybe your patient spontaneously recovered at the end of an operation and you don't need to give any reversal agent in that instance. So it just helps us to kind of know where we're at and confirm adequate recovery. I mean, we shouldn't just blindly give any drug. I'm a strong believer that both reversal, and when I say reversal, I think the evidence is mounting that there's less weakness with Sugammadex. Both reversal and quantitative monitoring work symbiotically. You can't have one without the other.
Excellent. So we've hit that time. Want to be cognizant of everybody's time. Dr. Renew, we greatly appreciate it. It was awesome.